had the opportunity, the distinct honor and privilege of being on Capitol Hill working on the Patient Protection and Affordable Care Act in 2008-9. It was a time of enormous optimism, hope, joy, enthusiasm. Those feelings were immediately followed by fear, anxiety, and dread. At the enormity of the task, it was confusing. I witnessed hundreds of the most expert, brilliant 21st century thinkers grapple with how to transform our current unjust, ineffective, and expensive healthcare system, representing approximately 1/6 of the gross domestic product of the United States, into an affordable, accessible, quality healthcare system. I thought, this is an enormous task. Nobody can do this. I thought back on my nearly 40 years of medical practice and knew that extending more coverage to more people wasn't going to get us there. So who could help us? And by now I'm sure you know who this gentleman is behind me. He's a 19th century pathologist who had some answers for us, some insight. He actually could illuminate the way, potentially. So what did he say? He said that all illness had two causes, the pathologic and the political. And our modern medical system has been so successful at understanding and even treating the pathologic that we have fallen in love with this biomedical model, so much so we apply it to the social and the political with little effect. So what are the clues to making a more accurate diagnosis and a more effective intervention? And I'm going to go through some of the clues. Here's one. This graph represents a social gradient in health. Simply put, the more money you make and the higher your social status, the healthier you are. There isn't, unfortunately, an optimal income and social status that confers the best health. No. The more money you make, the better your status, the healthier you are. Unfortunately, even for the wealthy, in a country like ours, where the gap between the low wage earners and the high wage earners is so wide, everybody's health is less than in countries where that gap is narrower. So even the wealthy would have an incentive to change the system. Now you might think that the reason why people with less money actually are less healthy is because they can't access the healthcare system. Well, only 15 to 20% of your health is related to access to the healthcare system. Believe it or not, 80 to 90% is related to your social status and your income, as dictated by your race, ethnicity, your sex, gender, age, and other social determinants. It's not because we're biologically different, although men and women are biologically different. That's a whole different talk. However, we're pretty much the same when it comes to what it takes to be healthy. That is, we all need clean air, clean water, nutritious food, a safe place to work, live, and play. We need close, loving, caring connections with other humans, and we need meaningful work. That's all the same. But when it comes to illness, we're different because our exposures are different in our different environments. And the treatments may need also to be different sometimes. For example, did you ever wonder why your neighbor who succumbed to some illness was treated with a particular medical invention and had a miraculous cure, that same illness befell you, and you were treated with a similar medication, and it didn't seem to be very effective for you? Or even worse, your best friend who got the same disease from you, treated with the same pill, actually got worse and had horrible side effects. It's because we're not all the same when it comes to illness, and yet we're treated the same. That's ineffective, leading to very expensive care. And another expensive care, another expensive practice, leading to ineffective treatment, is the medicalization of social problems. As you can see from this slide, there are many social ills in the world. Those social ills are given a medical diagnosis, legitimizing them in the healthcare system. You then develop a wonderful pill that treats that illness. And if you're lucky, you have a little relief in pain and symptoms, but you'll never treat the problem. You'll never cure the problem because it's not pathologic, it's not medical, it's social, it's political. Now, this is also very expensive, but how expensive is expensive? This graph shows us just how expensive it is. As you can see from the green line, the US spends more per capita on healthcare than any country in the world, nearly 2 times as much. And yet, our life expectancy, denoted by the yellow shaded area, is among the worst in the world. And you can substitute any other illness indicator, any other health indicator, and it will look almost identical. So by now I'm sure that you're a little depressed. Maybe you're as hopeless as I was in 2008 that we could ever solve this problem. But I'm confident we can. And here are 3 suggestions that might move us in the direction. First, we need to think more deeply about illness and wellness. We have all been so profoundly affected by racism and sexism and classism, ageism, ableism, homophobia and anti-Semitism that it's almost impossible for us to really think clearly about solutions to these problems, let alone work together across our diversity and our differences. We could create a think tank not like most think tanks that do research to really promote a particular social agenda. No, this think tank could be different, where we could actually have a group of committed people willing and able to heal themselves from the effects of such things as sexism and racism, and work across our divides. A second thing that we can do is to swim upstream and really deal with the root cause of our problems. Now, it's true, people are dying of heart disease, diabetes, cancer, drug overdoses, and we feel like we have an urgent, emergent problem we have to deal with. But we have resources and tools that actually can be used to intervene, to not only treat the acute problem and achieve short-term outcomes, but also to treat the upstream causes, the social dynamics that result in these acute problems. There are models. USAID has one of these models, and there are several other organizations. We should require all programs and research use these models if they're publicly funded. And lastly, we can work together. We can work together to implement the entire Patient Protection and Affordable Care Act, not just the insurance expansion provisions. There's workforce development and diversification. There's also public health and wellness and prevention measures. There's also comparative effectiveness. We can do this using a diversity lens. And the Canadians, for example, have an analytic tool that can help us there. We can do this. We can require that not only do we collect data by diversity, but we should report it and analyze it using that tool. We should also require all federally and state-funded programs and research use this kind of diversity analysis to be more effective. Now, this can be done. We can transform our ineffective, unjust, expensive healthcare system into a system that we can be proud of, that is accessible, that's quality and affordable. But it's going to take all of us. Will you join me?
Yeah.
Thank you.